And we're live in 5,
4, 3, 2,
1.
Good morning, everybody. Welcome to Neurology Grand Rounds. And I have the pleasure this morning to introduce Dr. Doherty, who's going to be giving the presentation. I asked Mike, what do you want me to say? And I really loved his answer. First, he said, short, no fluff. That's very much like Mike. So I will keep it relatively short. Mike studied history at Boston University, and he went to med school at Tufts. He did his internship, his neurology residency, and his epilepsy fellowship at the University of Washington. And he has been directing the epilepsy program here at Swedish for the last 10 years. He's a clinical professor at the University of Washington and WSU, and he's an associate director of the neuro program and works alongside myself here at Swedish. On a personal note, I will say that something that many of you know, Mike is a trusted and respected colleague. As you'll see this morning, he's intellectually curious. He's always asking questions, which I love in colleagues. He always finds humor at the right times, which helps every day. And for me, he makes Swedish neurology a better place to work. So thank you so much, Mike.
Thanks, Mike. I said no fluff. Today we're talking about responsive neurostimulation, 20 years of NeuroPace at the Swedish Epilepsy Center, Seattle. I have no disclosures. This talk, none of it was created with AI. We will be talking about couch surfing. This is basically an outline of what we'll talk about. One is refractory seizures. The second is surgical approaches to focal epilepsy. The third is mapping and how it showed a path to help people with hard-to-treat seizures that couldn't receive resective surgery. The fourth thing we're going to talk about is detections and stimulations off the RNS device. And the fifth, what the RNS device gives us back in terms of managing patients. We'll talk about outcomes from the RNS NeuroPace device, and then finally our Swedish experience. So let's talk about refractory seizures. This slide, you've probably seen many epilepsy talks start with this slide. This is a classic study from Kwan and Brody looking at who has hard-to-treat seizures in a pie chart. And what you'll see over to the right-hand side is that about 47% of patients will respond with seizure control in the first medicine trialed. Depending on whether you substitute for the second medicine if they didn't respond or add to the medicine they're already on, about 13 additional % of patients will respond to 2 medicines, then 3 to 4% will respond if you add a third medicine, and the remainder of patients, 36%, are not seizure-free. So that's in the year 2000. Bear this number in mind, 36% of people with epilepsy don't have control of their seizures with medications. We're going to keep coming back to that number through the talk. It's not just seizure freedom, though, that they're lacking in that group. That group is higher risk for depression, loss of autonomy, injury, sudden death in epilepsy, cognitive declines, relationship issues. There's a lot of burdens that come independent of the seizure number. So year 2000 comes along, and there was an absolute explosion of new medications available for us to treat people with seizures in 2000. And that led to considerable optimism among all of us who are just starting their training or otherwise treating people with seizures, that we were going to make a dent in the number of folks who didn't respond based on the sheer number of new medicines available. So back then, in your refractory patient with these great new brand name meds, we will no doubt improve their seizure control. That's kind of what the drug reps and me, young me, was believing and saying to people. But by 2018, so 18 years later, the numbers had barely budged. About 1/3 of patients are still not seizure-free on medications, despite all of those new medicines. So 18 years goes by, the number doesn't really budge. I am so glad I didn't go into academic medicine doing drug trials. So that's me pushing the boulder with my wife, cursing drug reps, and young me for the naivety that perhaps we shared, although the work was important. So in 2000, if meds didn't stop the seizures, what can you do for your epilepsy patient? So those of us who treat hard-to-treat patients, we typically will go looking for a zone of seizure onset or focal onset seizure by doing what's called phase 1 study, where we bring people in and paste EEG electrodes, put them in the ward, drop the medicines down, and trigger seizure activity, and try and figure out where does the seizure start. If we've got that basically lateralized, we may then move to a second phase 2 study where we actually place electrodes in the brain to take that localization down to a very small area where the seizure generator begins. And we use the EEG to figure out what is the most active area. So down in the left corner of this slide, you'll see ECOGs or electrocorticography recordings from a phase 2 study with intracranial electrodes with a seizure that starts over the hippocampal head and body and spreads out to the amygdala electrodes. That's what it looks like on a phase 2 study of focal onset seizure. So the second part, the surgical decision-making. What can we actually take and what do we save? So in epilepsy surgery, in fact, in functional neurosurgery, in any neurosurgery, we really want to preserve what works well and remove what is abnormal, if possible. So in epilepsy surgery, it's the generator of the seizure. So this slide, bear with me, shows a grove of sequoias, in Yellowstone National Park that was jeopardized by the Washburn fire in 2022, that the fire brigade spent enormous time saving this gorgeous part of the park and letting other parts of the park burn. So you can see where I didn't use AI. I made this slide myself, but this is areas that we can resect and areas we can't resect. There's places you can and cannot operate on. Typically, we think of the areas you can operate on as temporal, particularly if there's memory support on the other side, premotor frontal regions or parietal regions. There's other areas we won't touch. So if we can't get memory support on temporal structures from the contralateral side, we won't mess with temporal resections or hippocampal resection. We don't take primary motor cortex. We don't take occipital or visual cortex. We don't take visual radiations. We don't mess with the insula, or at least we didn't in 2004. And we don't mess with the thalamus. That's a golden rule of neurosurgery. Don't mess with the thalamus. Also, aphasia paths, be it Broca's, Wernicke's, or conduction. We don't hurt or damage those. So we're trying to avoid all these really important parts of our brain in our epilepsy surgery and confining it to areas that we may be able to get away with taking tissue out of. This is the absolute classic favorite surgical operation for us in epilepsy. It's a right anterior medial temporal resection, an en-bloc resection in someone with what's called mesial temporal sclerosis. This has consistently the best outcome in terms of neuropsychological scores and seizure freedom, with the seizure freedom rates in this population, if they're refractory and have mesial temporal sclerosis, running 80 to 90%. Back at the turn of this millennia in the year 2000, you can see that the numbers of these surgeries were going up and up and up. And it seemed like a really exciting time for us to progress with epilepsy resective surgery. What else limits our resections? Well, multifocality. If we have more than one zone of onset, genetics, particularly complex genetics on channelopathies, or generalized epilepsies even, we're not going to do resective surgery. Patient preferences, cultural differences, surgical concerns about blood supply to the area we're looking at, or to the scalp, or to the scar site, the clot risk, the technical difficulty of the surgery, insurance, et cetera. There's a number of other issues independent of the zone of onset that we consider in whether or not it's safe to resect tissue. So one of the ways we go through and determine is it safe to take tissue is through brain mapping. And brain mapping, here's an example from a patient we did several months ago with stereo EEG electrodes in. These stereo EEG electrodes are basically fence posted around a cortical dysplasia this patient has. And in mapping, we are putting current back down the electrodes that are surrounding this location and delivering that current to areas of concern and seeing what they do. So in this patient specifically, we were trying to figure out, are we close to visual radiations that we might jeopardize as they move from the temporal lobe back to the occipital cortex? So what you see is a 5-second stimulus with the black bar there, followed by what are called after discharges. After discharges are, in essence, spontaneous depolarizations that are kind of trying to harness into a seizure. So the stimulation here almost triggered a seizure, but fortunately, within 3 or 4 seconds, the after discharges have ended. We do this mapping while patients are awake, so we're talking with them during this time, and one of the goals in the mapping is to not trigger a seizure, because that basically ends our mapping session. So we're running a very close line in terms of seeing what the tissue does and triggering seizure. So that's something we see after discharge provocation, we see in mapping all the time. And Ron Lesser's team at Hopkins saw this. Here's their stimulation. Here are their after discharges, and then they decide to go ahead and re-stimulate. And you can see with the re-stimulation, that discharge activity, the after discharges end. So this is an N of 1 study. We see it all the time on the ward. We do this. We will re-stimulate if we see after discharges. But Lesser's smart enough to write this up. So N of 1 write-up goes in Journal of Neurology, 1999. So borrowing from the cardiologist, it's apparent then that we have some potential to use stimulation to shock an abnormal rhythm. So in cardiology, they have rhythms, they shock, ventricular fibrillation, ventricular tachycardia. These are important rhythms to shock because if they persist, they'll kill you. So here's our brief and shocking timeline. There's a lot of data on this. I don't need you to go crazy on it, but basically, 1930s, they start seeing in animal models, if you stimulate the vagus nerve, you can bring down seizure numbers. Then exposed cardiac stimulation stopped fibrillations with an external defibrillator in the 40s. First pacemakers in the 50s and 60s using mercury batteries. In the 60s and 70s, the mercury batteries for pacemaker are replaced with lithium batteries and encased in a titanium core. And this is really the key technological developments that help shape the rest of our stimulator venture. 1987 trials for Cyberonics VNS begin. FDA approves it 10 years later. FDA approves deep brain stimulation for essential tremor in 97. Lesser writes that paper in 1999. The FDA approves deep brain stimulation for Parkinson's, 2004. The first RNS NeuroPace device is implanted in 2014. RNS NeuroPace is FDA approved. So that last slide had some terms on it. One of them was open loop systems. By that we mean that there's just a drumbeat of stimulus that's going up either through peripheral nerve in the vagus nerve or through deep thalamic structures with a deep brain stimulator. A stimulus potential is just going over and over and over and over and over again to tell the brain, don't have a seizure, don't have a seizure, don't have a seizure, don't have a seizure. Those messages are relayed, we think, through the thalamus and the vagus nerve ultimately, the vagus acting as a highway to carry the signal to the thalamus. And in the deep brain stimulator systems, they do plug straight into thalamic nuclei. Closed loop systems are different though. They're ones that are looking for abnormal rhythms and then stimulating based on seeing the abnormal rhythm. And that's where the NeuroPace device is very different. The responsive neurostimulator, or RNS NeuroPace, has 2 surveillance sites. And these are examples from 4 of our patients here at Swedish. 4 contact electrodes placed in 2 different locations attached to a generator and battery, all of which is housed in the same can or unit that is placed in the skull. So Lesser's N of 1 observation turns into translational research that turns into a device that looks like this. So schematically, it's probably a little bit easier to see than those scout films of the skull. The device is bolted into the skull. A small window of skull is removed to fit the device. The device is about as thick as skull. You can see there's a saddle here where the wires come out, and there's wires moving down to a locus or focus. Oops. How do we get there? A focus of seizure activity that's illustrated in purple with 2 different electrode types in this particular example. One is a strip electrode. You may not be able to see it here, but where's the video? That's what the strip electrode looks like. It's small, flexible, 4 contacts. Or a depth electrode, small, flexible. At the very end here, there are 4 contacts that plug in on this end to the device. You could set this up with 2 depth electrodes or 2 strip electrodes or 1 depth and 1 strip. Those are your options in placing this to survey a site of concern. So here's the exciting part. You probably, hopefully recognize this. This is Swedish Hospital's First Hill campus. And the first device, the first RNS NeuroPace, was placed here at Swedish in 2004, the first in the world in live ambulatory patient. Obviously, they were anesthetized for the placement, but once it was in, they were ambulatory and out of here. So one of the big firsts in neurology for us here at Swedish, we're super thrilled about that. There's other firsts we've had at Swedish. Swedish was the host or site for the first dialysis unit, outpatient dialysis unit, with Belding Scribner through University of Washington. And more recently, Merrill Spencer at Swedish Vascular developed carotid duplex studies to look at vascular flow into the brain. Steve Monteith here also focused ultrasound brain mets, first to use that in the world, also the first to really develop and use the Microsoft HoloLens for surgical planning. So we have a few neat firsts here, though those firsts come with a price tag. The RNS company, NeuroPace company, I asked Marty Morell, who runs NeuroPace, how much did your trial to development to FDA approval cost? A couple weeks later, she got back to me and said in excess of $300 million. So not a cheap endeavor, but probably similar to the cost for most new drug trials, frankly. And a labor of love for the team that did it. So remember, N of 1 moves to a useful FDA-approved device by 2014. In 15 years, we go from an observation to a useful device. So part 4, we're moving really quickly here, which is great. Detections and stimulations. So what does this device do? How does it detect and stimulate? So there's going to be a couple beach pictures coming up, mainly to make us feel better about the miserable Seattle weather we've been having lately. This is a beach in New Zealand on the Coromandel Peninsula where my son and wife are walking down the beach past the lifeguards there. It's called Warm Sands Beach, and they're basically at the spot where a hot spring bubbles out of the beach. And if you walk down there, you will detect and feel stimulated by the hot water under your feet. And if it's too hot, you'll get in the Pacific and cool off. So an implanted stimulator, this is what the device can do. So here's a picture off the Facebook page for NeuroPace showing what a patient does when they upload data for us to look at, they hold a wand over their device. It's connected to a laptop. The laptop wirelessly communicates that data they're uploading to a management system called PDMS that we can look at. And the data they collect includes things like long events, electrocorticography, stimulations and detections per hour. I'll show you what these uploads look like. So here is an example, for instance, of a corticography or EEG recording on the surveillance sites with channels 1 through 2 representing hippocampal recordings and channels 3 and 4 representing amygdala recordings. And what you'll see is a whole bunch, whoops, sorry, that didn't work, did it? Bear with me. You'll see a whole bunch of spikes that the device is picking up with the vertical blue line where it says TX. It may be hard to see TX, but you're seeing spikes that the detectors have picked up and stimulated for, and moving through about an 80-second epoch here, which is the length of the corticography displayed. You can see on channel 2, there's a development of a more focused mini seizure activity or discharge potentials that the device saw but was unable to stop. So that's a pretty common electrocorticography recording that we might see. That potential on channel 2 where it turns into the bridge-shaped blueness, that doesn't necessarily mean it was a seizure. It just means the cortex there was more than irritated. So how do we teach the device to recognize good from bad? That's something that the physician and the field engineers from RNS spend a lot of time on. And as epilepsy providers, we should be, if you're not, you don't belong in this field, but we should be really interested in rhythms. So to define weird rhythms, you have to be observant. So in this example, you've got waves, you've got the pylons, you've got the mountain, but the weird rhythm is really this guy. What are those? We don't, that's something bizarre. That's not normal. That's something that as an epilepsy provider, that I'm looking for weird rhythms. I'm trying to find them. I'm trying to figure out what they mean for people, be it on an EEG or the electrocorticography for the NeuroPace. So the way you can look at a sine wave pattern, a wave pattern, and tell a difference in the sine wave pattern between one epoch of time and another is you can use feature detectors. And those feature detectors, the most common one we typically use is one called bandpass, or an amplitude detector that when the amplitude of the waveform is exceeded, the device picks that up and stimulates based on that amplitude exception. There's a second way you can look at a rhythm to see if it's changed. You can use area under the curve. You may remember that from calculus. 10th grade, Tony Hill, my math teacher, was teaching us about calculus, and he was telling us about area under the curve. And I distinctly remember, I went to an all-boys school, one of the boys saying, "Mr. Hill, when are we ever going to use area under the curve?" So I'm going to read the answer. So the answer is, the determination of stimulation onset programming for seizure cessation through an implanted responsive neurostimulator known as RNS NeuroPace. That's when you're going to use area under the curve. If I said that back then, that would be my mic drop moment. Of course, it would have meant nothing then, but the area under the curve is one way you can tell, based on changes in the area under the curve, is there a stimulation, or is there a pattern difference? A final way you can think of looking at sine waves and telling the difference between one epoch of time and another and a change of concern is using a paradigm of line length. So imagine that the waveform is a piece of string, you pull it straight. Depending on how many cycles it has, it might be very long or very short. That difference you can use as a stimulation or a detection point to initiate stimulation. Here, for example, is the RNS platform on how to define some of those stimulation detection algorithms. You can see down below there's a bandpass suggesting high or low frequencies are of concern, and a little bit of bandpass in terms of duration of the waveform. An example, if you're not quite there yet, here's a kayak excursion to Hood Head on Hood Canal. This was this past summer. At the end of Hood Head, there's a driftwood dragon that I like to see. It's built on the beach. It's public art. It's gorgeous. So you kayak out to this site. One of the days when I was kayaking out, we had, in essence, an atmospheric band pass where the fog layer was reflected in the water layer, and we're stuck in the visible band. We're safe here, but that's one idea of thinking of bandpass as a blinker. The other way is to, when you finally get to the driftwood dragon, this is what it looks like. So, and on the lateral view, this is what it looks like. So you can see the driftwood dragon has a waveform to its body, and you can see its head exceeds the amplitude. And when it does, that's what we need to zap or shock. So when it exceeds that bandpass, that's when the stimulator shocks the rhythm. So the point Hannon dragon hopefully is neutralized by the shockage. The therapies delivered by the device, once it recognizes the threat, RNS typically will stimulate. If it still sees a risk, it will stimulate multiple times, up to 5 times before it concludes. That's what's called a long event. You can do 2 different bursts of therapy. You can do therapy over 2 different locations. In those 5 therapies it delivers, you could vary the therapy if you wanted, although that makes it extremely confusing to know which therapies actually made a difference. This is what the programming page looks like. And I'm not going to go in depth into programming because it would bore you to tears, but suffice it to say, there's different ways you can arrange the polarity of the stimulation on the electrodes you're using, positive and negative, within the site. For instance, here in the hippocampus on burst 1, you can see it's positive and negative. You can stimulate between sites. Hippocampus could be all negative, amygdala could be all positive. You could stimulate between the site and the can, or the actual generator, defining the generator as positive or negative. So you could build a really big field of stimulus. On the right-hand side, you'll see there's a lot of different program settings, 3 milliamps, pulse width, burst duration, frequency. You can play around with all of those, and those are quite similar to the settings you can use in, say, a vagus nerve or deep brain stimulator as well. Those aren't necessarily unique to the RNS. These are common ways you deliver stimulus, but those are all manipulatable stimulation ideas. What we don't really know is what is the best stimulation for layer 1 of the cortex, or the left temporal versus the right temporal, or the white matter or gray matter. We're still working our way through various charge densities and locations and stimulation potentials that really are extremely individualized for the patient. So we're coming back to this N of 1 idea. So here's the point Hannon dragon. We are harnessing that stimulation to calm activity. We're doing thousands of stimulations a day, and therefore the stimulation needs to be subclinical. This isn't defibrillation. We're not shocking you out of a malicious heart rhythm that basically makes you jump off the bed. We're in the exam room testing the stimulation and checking with the patient. Do you notice anything? Do you feel anything? And if they don't, fantastic. That's exactly where we want to be. We want to do a subclinical stimulus thousands of times a day often. So in essence, we can do some outpatient in-room mapping with the RNS device. So here's where we're going to take a little excursion to what does the RNS data show us. And I'm going to use a contorted metaphor, and hopefully I can keep you on this one. But here's Piha Beach in New Zealand. It's one of the world's 50 top beaches. It's a gorgeous place. It's probably unfamiliar to most of us, but it is spectacular. I want you to imagine for a second that 64% of well-treated epilepsy patients who are seizure-free get to swim at Piha Beach, and they swim in the site where the lifeguards are. They swim between the flags, there's lifeguards, there's rescue boats, and they're by and large doing great, having a good time, well-controlled. Obviously the metaphor, this is the medicated epilepsy patients who are doing great. So you remember that number, 36% of people are not well controlled. Well, where do they get to go on Piha Beach? They get to go way over here, behind the rock headland here, to a place called the Blue Pool, where these monster waves from the Tasman Sea push through this narrow gap, and they can play in this part. And If you see down here, maybe it looks like a little rock. That is in fact 3 people sitting on an inflatable couch. And those are the 3 people. And I'll give you one guess to make up your mind out of Zen's mom, and Christina, whose idea it was to take an inflatable couch into the surf. Anyway, for the purposes of this metaphor, for the next few minutes, I need you to imagine that couch surfing, the literal version of floating on an inflatable couch in high surf, is not a voluntary experience. I want you to assume that the waves that they're exposed to are uncountable, and that those waves and the environment there is extraordinarily dangerous. You can see the rocks in the background. By the idea that the wave is uncountable, in our refractory patients, really all of our epilepsy patients, it's hard for them to keep an accurate diary of the number of seizures they have, in part because many of the seizures fry or damage areas of cortex that help make memory. Both during the seizure, they can't make the memory after that they had the seizure, or over time, their ability to record the seizure is hard, or alternatively, they're having a lot of seizures they didn't even know about often when they're asleep. You can see there that the wave isn't exactly a tiny one and done wave. It's basically 50 yards of white water 4 feet high. So a scary environment, right? So we define that group as epilepsy providers as needing help. So we want to get those guys over to the guarded beach. So this beach, Piha Beach, the water flows back to the guarded beach, not along the side there. It actually flows through a gap in the rock there in a small tunnel. I'll show you what this looks like in a second. But in any case, to get people over to the guarded beach where they're going to do better, we need to do our phase 1 and phase 2 study. We need to present data. We need to determine the focus, the zone of onset, and we need to convince people that, say, either a resective surgery or an RNS stimulator is going to make sense for them. So here's the gap that the water flows through. So phase 1, phase 2. Think of the gap as the phase 1, phase 2 study. And remember, this is not voluntary. Zen was the correct answer, by the way. It was Zen's idea to do the inflatable couch surfing. Anyway, Zen's stuck on this couch. We're telling him, you need to get to that other beach, and we're going to take you through this narrow gap. And it's going to be a little bit weird, but we want you to do this. This is where the gap dumps out into, not necessarily a much kinder beach, but at least this beach, from where the picture is taken, that's where the lifeguards are. There's people in the water who are competent. There's people behind fishing off the rocks. There's lots of people here looking over to help. But you can't get around this idea that the gap is sort of terrifying, this flow through the gap. So I'm imagining conversations here internally, thought bubbles. So the patient, the gap's terrifying. There's no easy way out from this nightmare. Maybe they won't find where the seizures start, or maybe they figure out I'm not a good candidate for surgery. This is really scary. And if you don't recognize that's the emotion your patient's going through in a surgical workup, you shouldn't be treating people with hard-to-treat seizures. This is scary stuff. From my perspective, when we push someone through the gap, through the phase 1 or phase 2 study, I'm looking as hard as I can. Did I figure out the best place for the resection or the RNS electrodes to go? I only see what I can see during the monitoring when we can safely drop medicines down and trigger events. So I have a somewhat artificial view of where the events start. I don't know where the events start when people are out and about wandering around on their medications. I only see what I can see when I'm dropping meds during monitoring in the hospital. Nevertheless, I've got the data, I've conferenced it, I've run it by my colleagues, the epilepsy docs, the surgeon, the neuroradiologist, and we're all go for a plan for NeuroPace for Zen. So the neurosurgeon, what's their thought bubble? So epi docs want me to put an RNS NeuroPace system in this refractory epilepsy guy. It's like they want me to bring this guy stuck on an inflatable couch through a rock-lined tunnel 7 feet wide with, get this, riptide running through, and dude, it gets better. The tunnel dumps out into a surf beach with more rocks, and did I mention the inflatable couch and sharp rock part? Yeah, it's a plan so crazy it just might work. I'm in. Yeah, obviously, obviously the neurosurgeon doesn't say that, but you want a neurosurgeon who's conferenced your data and come up with a plan that's safe and appropriate from their point of view. They're integral in planning a trajectory for surveillance electrodes, a skull site that's well perfused with blood, a surgical scar site that they know is going to survive if we have to do battery replacements. So pre-RNS, that's kind of what the look through the gap looks like. It's black and white, and there's a freight train of water coming through on a wave back there. It's scary. Post-RNS, we have, I'm going to use PDMS vision. So we see patient data management system vision. We can see stuff that we couldn't previously. And what do I mean by that? So here's some of the data that patients upload that we look at and can play around with. This is data from one of my patients. You can basically see detections and stimulations by hour of day. You can see a nighttime predilection for more detections and stimulation when daytime seems calmer for them. We use that data in this patient to match with their glucose. So this patient's a type 1 diabetic and has a Dexcom monitor. So we've got brain data basically in real time and glucose data basically in real time, and we can twin that data and begin studying it and to see some physiologies that pop out. And one of the things that popped out for us was that the higher the glucose, the lower the detections. The lower the glucose, the more the detections. Does that mean it's an abnormal phenomenon? Probably not. It might just mean that when people are asleep and their glucose drops, the waveform amplitudes increase and therefore are triggering the detectors and stimulators. It's an argument that's, I think, reasonable to make. In sleep, you get delta sleep, high amplitude slow waves. You also get vertex sharp waves and K complexes, all of which make trigger the RNS device to think that's a different pattern and rhythm worth stimulating. So is it normal or abnormal physiology? Don't really know. Is it interesting? Absolutely. Is it N of 1? Yeah. So what? This is interesting stuff. Glucose clearly plays a role in some of the excitability in our cortex, and we can show it. What else can we see? Detections, stimulations per day over months. So this is July to December in one of our patients. And you can see that there's patterns of spiking that are occurring perhaps 10 to 12 days throughout that entire cycle. In women, there's a catamenial pattern fairly often, meaning a menstrual-associated pattern of stimulations and seizure risk that occurs ovulatory, perimenstrual, menstrual, being 3 phases of their menses cycle that often trigger seizure activity. But from studies involving men and women, we were able to see, Maxime Baud and Vikram Rao and others, that there are cycles that are occurring every 7 to 10 days for lots of people. We don't know what those cycles are. We don't know what's triggering them. We don't know why they occur. Maybe you could make a postulation, and this is reasonable, that for men, every 7 days watching football and getting drunk might trigger a recurrence of seizure activity. There's hypotheses you can basically throw out based on cycles that help you manage behaviors. So perhaps this slide is one of the more important ones. These are the tally of long events. So long events per the RNS are a series of 5 stimulations given in a row becomes a long event, and it tallies that long event, and you can look at the graphs of long events. This is a proxy for seizure activity. Generally, we worry a little bit more about the frequency of long events than we do about the frequency of detections and stimulations. So in this pattern, you see, again, this is May through September, months-long data. You can see from June 1st to June 16th, there's a big uptick in long events. So I look at my NeuroPace patients' data every 30 days and review it, write a note. If I see something like this, I'm asking our team to touch base with our patients, say, hey, something weird happened June 1st to June 16. What was it? Did you miss your meds? Did pharmacy not fill them? Were you stressed out? Had you traveled to Ireland? Were you jet lagged? There's all these things that we can start using to check on our patients that otherwise we would not have been able to do because their seizure diaries, by and large, are way worse than the RNS-generated data that truly shows us that they're electrically unstable. So this is light years ahead of the other stimulator devices. This management system where we can see patterns is extraordinarily useful, and even 20 years in is amazing technology. Here's some examples on how that data was used by David Spencer and Barbara Jobst and Nathan Fountain to look at locations of seizure onset by clock time, where the long episodes were used to map out, well, the neocortex and the temporal lobe and the frontal lobe have way more seizures at night. The mesial temporal or amygdala hippocampal electrode onsets have seizures all through the day. So, okay, what does that really mean? Well, it means that there are risk behaviors for locations that are different. And what underpins them? We don't know. This is data that Katie Kinnear and Nicole Warner and myself and Alan Holtner looked at one of our patients for detections, not detections, I'm sorry, seizure times of onset based on a left and right temporal surveillance site, showing that there are different times of onset for risk of seizure in this patient. So does that mean that there are switches going on and off for various locations based on glucose or other things? Yeah, maybe. Regardless, this is exciting. This is hypothesis-generating data that lets us think way more constructively about what is epilepsy, where is it coming from, what locations do what and why, and do different locations have different risks for seizure? So here's another upload of just a pretty standard upload where you can see some breakthrough seizures August 6th. August 7th, looks like the device stopped the event. July 24th, the patient swiped a magnet to mark a series of time that they were worried about something that didn't actually show much. But these are the sorts of data we can see on the RNS, exact time of seizure right down to the second. Okay, great. Seriously, what happened to Zen after the gap? I don't really care about the rest that you've been talking about. What happened to Zen? And I don't mean metaphorically. Where is he? So there he is. He's out. He's on the good beach. He's doing the hang loose, bilateral hang loose. He's facing the beach with the couch, which technically isn't going to work, but we'll talk about that in a minute. And then along comes the large freight train wave and basically bumps him off the couch. And there he is swimming to shore. So kids, neurosurgeons, and epilepsy fellows, please do not try this. Zen is an experienced surfer. He's a longboard champion for New Zealand. He represents that country. He knows what he's doing in the surf. What happened to the couch? It looked stylish and expensive. So here's the couch floating along, and a young surfer spies it along with his friend. And wait, what? The surfer, the Grom, gets on the couch and actually manages to surf it. So obviously this is an absurd example, but it's fun, right? And the point I'm trying to make here is that this kid was able to ride that couch in the surf with help of a coach or someone in the background actually holding them steady and launching them onto the wave. I didn't see the second figure for a long time. I was getting ready for this talk, but then looking carefully, you can see someone's actually stabilizing the couch for the kid and setting him up for a successful wave ride. So imagine it's not the kid that is actually Zen on the couch. We're the coach. We're coaching through the RNS on what he needs to do on his behavior, but we're also changing our settings on stimulation and detection based on those electrocorticography and other data that we're receiving from the patient data management system. So we're talking about timing of med choices, dosing formulations. Do we use long or short-acting meds? Do we define peak doses, trough doses, breakthroughs during trough dose? Do we define compliance? What did their magnet swipe say? So frankly, there's a lot of coaching that we can do with the RNS in place that we can't do for any of our other patients to the degree of specificity and sensitivity that the RNS permits us. That, for me, is why this device is so interesting. And if you're still thinking more about the couch, yes, a perpendicular takeoff is better to ride it and surf rather than facing the wave straight on. And furthermore, if you want to actually surf this wave, you probably want to shift your center of gravity a little bit to Zen's left here so that the couch slides down the wave and stays on. Anyway, more than you wanted on couch surfing. So here's the part that I like. It's the feedback on how we're doing, the patient data management service. So let's jump to RNS outcomes. Back to Washington State. This is Cutts Island State Park. 3 good stimulator options. I'm not here to throw any company under the bus or device or system under the bus. These are all good systems for various reasons. Vagus nerve comes out in 1997, RNS 2014, and deep brain stimulation through the anterior thalamic nuclei for epilepsy is FDA approved in 2018. So the RNS NeuroPace study, the feasibility, pivotal, and long-term trial, Swedish participated in all of those. What were the results ultimately? Well, at least initially, the 50% responder rate at the end of the double-blind phase, i.e. 20 weeks. A responder rate of 50% means when you have a greater than 50% reduction in seizures, how many people achieve that? So 29% of the patients at the end of 20 weeks, at 1 year, 44%. And if you keep going down, it just gets better and better the longer we're using the device, such that in the long-term trials and beyond, it's over 73% are 50% responders. We've got 2-year trial-based data of seizure freedom, 9%, and then seizure freedom over a longer duration, up to 28%. Cognition did better with the RNS than it did with medication management. So the cognitive outcomes for people who had the RNS placed showed that eloquent cortex was saved, or alternatively did better with the RNS in place, presumably because of decreased seizure burdens, but possibly also because we could change or alter medications to perhaps alter cognition more. So which stimulator might be best? This isn't a head-to-head series. This is by and large abstracted from a couple data points, Rivlin's review in Lancet Neurology, as well as Fisher's Santé trial. You can see that the DBS, the VNS, and the RNS all have over 50% reduction or responder rate with perhaps a high risk of bias. The seizure freedom rates for DBS at 2 years, 7.4, RNS, 9%. And then in longer duration seizure freedom, VNS, 8%, although I frankly don't believe that. It seems a little bit high. DBS, 13 to 18%, and RNS, 28%. So 3 good stimulator choices. Why might you use one over the other? The VNS is good for clustered events. It's good for keeping people alive. It's good for keeping people out of the ER. It's good for status epilepticus. It's good for non-compliant patients. It's a really straightforward device to use. It's surgically low risk. The DBS is good for hard to pin down seizures. Where do they start? How do they spread? Is it multifocal to the point of half a dozen or a dozen zones of onset? And then the RNS we've found is really good for focal onset seizure, particularly if it comes from mesial temporal structures or neocortical. Plus, it has feedback, so it lets you coach people way better than you otherwise might have. So Swedish, here's Green Lake on a gorgeous day. Outcomes of RNS for us. So we had a responder rate over time that approached 85%, and super responders where they had greater than a 90% reduction at 45%. The seizure severity by most patients was ranked as better, and by 40% as much better. The locations of onset, 85% responders for mesial temporal onset, mesial plus, meaning a location, say, in the hippocampus, and then a second stimulation electrode in some neocortical or second location, about 75% responders. And then neocortical, probably mostly frontal here, 94% responders. So really good outcomes for some of our focal patients. Thalamic, we're still getting our heads wrapped around using the thalamic stimulations. I don't quite have the data yet on that. It's been a little bit of a struggle to feel as good about thalamic stimulations, at least in my patients, compared to some of these other sites, but that's work we're still working on. So we put in a fancy PowerPoint arrow here for RNS Swedish and the Swedish flag. 50% responder rate, we're doing really well compared to trial data. Seizure freedom, 2-year follow-up based on the trial we participated in was 13%. Seizure freedom greater than 6 months, we're about 15%. And why is that? We're not quite as high as some of the trial data. On the other hand, I do have some suspicions about some of the trial data, then that once you start looking at the PDMS, you do start seeing events that look by and large very seizure-like, but the patient didn't know it. So the counts here on these responder rates still remain not necessarily through any objective data. They still remain for each of these. The responder rates still remain based on patient surveys of seizure frequency. So what else can we do? 2 surveillance sites, same patient, several years in. One site we could help. We could stimulate their seizures and make them stop. And when we couldn't, the stimulations made no difference. So in 2 years of ambulatory intracranial data in real time using medications, we're able to see a zone of onset in a multifocal patient, one of which is malicious and horrific and can't be controlled, and the other is doing great. This is the issue back when we were looking at the slide in the gap, that when we're monitoring patients in the hospital ward, it's an artificial environment. We're dropping meds down. We don't know exactly the med effects disproportionately on what location and how they do, what they do. But when we've got an ambulatory patient with intracranial data, we can start to see this. So the decision tree here was, let's take out that area that wasn't helping. And this patient went to resective surgery despite being multifocal and did well long-term with far fewer seizures after resection of the zone of onset that couldn't be controlled with medication or RNS. This is data that we participated in from Larry Hirsch and others in the RNS group that shows they use similar strategies to use long-term monitoring with RNS to make a surgical decision based on months, if not years of data, rather than intracranial data collected over a week or a week and a half. What's this slide? This slide basically shows, remember, turn of the century, the number of resective surgeries for temporal lobes. It was looking great. The numbers were up and up and up. This is data from Britain, from Yorkshire and Sussex, and their epilepsy surgery center there with a referral catchment of 3 million patients in their referral zone shows that the number of resective surgeries basically plummeted over the next 14 to 15 years. And this is a pattern that we've seen too, that the number of actual easy to define and resect surgeries has gone down, and yet the number of really hard to treat patients hasn't. So we have to be familiar with the use of these stimulators in moderating seizure frequency and severity. And I guess, yeah, we're making a dent in the number of patients who are not seizure-free on medications through use of the stimulators, but the issues that bother people in our clinic aren't necessarily always seizure number, right? It's these issues on the right side: depression, autonomy loss, injury, cognitive decline, relationship issues. I crossed out SUDEP there because most of these devices are quite good at lowering the risk of sudden death in epilepsy. Those issues, 20 years in, they're not unique to our epilepsy patients. They're basically issues we all suffer from in some degree. And following people over this long, long time, however we can help them deal with those issues becomes really, really important. And the RNS does let you take a peek into some of that in terms of how their seizure control is going. That helps open a door and a window to this idea, again, of coaching people, of getting them better and healthier and safer in ways that let them be more autonomous and independent. Couple final notes. This is one of my patients who has the RNS device. She had a temporal lobectomy earlier. The device was placed, and for years she did great, no problems in seizure-free. But what we started knowing over time is the number of detections started going down, paralleling a course of her Alzheimer's. She was diagnosed with Alzheimer's in our memory disorder clinic. And this to me is super fascinating. So might RNS give us a window into other processes here? Is this a decline in cognitive firepower evident on the stimulator's detections here in this specific patient? You can see also that her patterns of uploads drop off the more demented she gets. Those are those white gaps towards the right side of that histogram. So might we be able to use detection systems like RNS to measure cognitive decline or cognitive trials for preservation of memory or preservation of brain function? So are there other curveball ways we can use this device to survey degenerative or other processes in neuroscience? I'm going to skip this slide and jump to a conclusion. So what's the conclusion? The neurosurgical take-home: when couch surfing, orient the inflatable couch perpendicular to the wave direction. Obviously, we're joking there, but in well-chosen focal epilepsy candidates, RNS NeuroPace is an effective and powerful tool to moderate seizure activity that may lead to potential seizure cessation, but does result in more effective coaching on how to manage your patient's epilepsy. I don't think we've remotely exhausted the potentials here for using this device, not just in epilepsy. It's beautiful technology. It's really interesting. It's fun to work with. And there's a ton of people that I hope share my enthusiasm for it. Special shout out to Derek Schulte, our RNS field engineer, who's worked with us for a long time on managing our patient settings and stimulations and troubleshooting, along with all of these folks that were instrumental in helping Swedish build and maintain and continue to use RNS. Thank you. Fortunately, I can't see any questions, but are there any questions from the audience? Yeah, Mike.
Thanks for the great talk. Yeah, I was just wondering, because you have this live record in these patients and you're able to go back and say, what was going on at the time where different events were noticed, have you been able to discover any provocations or environmental stimulants that are going on with patients that previously you just didn't have the ability to recognize?
Yeah, I can think one off the bat right away. And it's going to sound dumb in retrospect, but it was one of those 7-day cycles of breakdown and seizure frequency. And I was puzzling over what the hell's going on, but then you look closely, it's every Sunday, every Saturday night, this guy was drinking. And his seizure diary didn't show that. His spouse never mentioned it. So it was a useful opening of an argument, or not argument, a counseling towards your drinking behaviors and binge intoxication that were provoking your seizure control that we didn't really know about, that was totally missed. And the RNS gave us this clue that this weekend behavior was maladaptive and hurtful for this guy. And he's doing better. He's acknowledged it. Yeah, there's sometimes just these things that are really, really obvious. The other examples would be these bumps where you suddenly see an uptick. You call them, and turns out the pharmacy is still doing their prior auth and hasn't filled their controlled substance. Man, I could just tell you, and Tom Cunningham, one of our epilepsy nurses in the background here, can tell you how many times people come up complaining of, yeah, pharmacy didn't fill the controlled substance. They waited till the last minute, realized they didn't have it on stock. I missed it for 3 days. It wasn't my fault. That's those patients getting screwed over by both the controlled substance classification of some of our medications and pharmacy not filling it. So yeah, we pick up this stuff all the time, and you could argue that those sorts of issues are exactly the reason why that needle doesn't budge on the really hard to treat patients. So these are some issues beyond their control where medications and stimulators just aren't going to help them if they don't have those things always there present for them. So for me, it's not that I'm cynical about the goal of getting people to zero all epilepsy patients are seizure-free. There are some practical issues that are very nuts and bolts that just are unassailable in current form. Other questions? Looks like Hannah, you might have some there.
Maybe something in the chat. Okay, let's see here, thanks. Thank you for an engaging talk. Can you comment on sequencing, if possible, of PACE, VNS, and DBS after each other?
I assume what that question is driving at is, let's say your patient got a VNS first and didn't do well with the VNS. Do you go to the RNS second or the DBS? Or let's say they're a failure of a stimulator and you want to try a different one. I think that's what the question means, and that's how I'll answer it. But in general, we are trying to come up with the most aggressive and safest stimulator option right off the bat so that hopefully we can skip a second operation later. We're not really trying to aim for what's easiest and then move to what's hardest. We want to go straight to what's safest and most aggressive right off the bat. So yeah, we've had a few patients where we did RNS and it didn't work as well as we wanted, so we put in a VNS. We've had it the other way around more often. The VNS was in place, and when RNS was approved, we moved to RNS. It really is individualized medicine. So at least our thrust here is to look for the safest yet most aggressive plan we can come up with. Other questions?
There's another question. Can you use RNS in generalized epilepsy?
Yeah, I think that's right now, and correct me if I'm wrong, Derek, but I think Children's Hospital is running trial along with other sites for, say, Lennox-Gastaut epilepsy. There is a trial. Yeah, so that there are trials for complex, more generalized appearing epilepsy, but we are not using it for generalized epilepsy at this point. We're using it for complex, more than two-site multifocal epilepsy patients now using thalamic stimulations. Again, that's something we're still trying to figure out. Is it really effective, or is the DBS just an easier surgical approach with a better, faster time to therapy? Don't know the answer to that yet. So yes, the generalized epilepsies, you can use a VNS reasonably effectively in that group. But DBS and RNS, we're still trying to figure out, at least at Swedish, which one is preferred. Other thoughts or questions?
I have one other question. So it wouldn't be right if we didn't have a question related to AI. So is there a role for AI to improve like waveform pattern recognition and improve the efficiency of this technology?
Yeah, absolutely. So RNS NeuroPace does have a system that uses AI to help pool the aggregate data from all of their patients to help define strategies of stimulation. Correct me if I'm wrong, Derek. So they are already using that to help us with some of the stimulation settings, because you can imagine that 60 sites across the US, perhaps as it expands elsewhere, hundreds and hundreds of patients, hopefully patterns would start to emerge that are useful. And that the best way to sort through those isn't going to be calling someone on the phone or emailing them. It's going to be through big data, sifting through. AI, I don't see sitting down face-to-face in front of a patient and counseling them, though. So it's never going to be that face-to-face interaction. Anything else, Mike?
Yeah, they're still coming in. So let's see, we got, do you consider both RNS and surgery planning for complex seizures?
Yeah, absolutely. So if we have a patient who we've defined a zone of onset and is being considered for epilepsy surgery, our first hope is that they actually would meet candidacy for resective surgery, because in general, the resective surgical outcomes are safer and better if we get a site of non-eloquent cortex. So that's where the mapping really helps us figure out, are they safe to go to resective surgery, or are they not? And if they're not, then yes, next step would presumably be RNS NeuroPace or one of the other stimulator ideas based on surgical safety, patient preference, risks, benefits, covered both by us with the multidisciplinary conference and then by the surgeon to the patient. So yeah, we do consider that, absolutely.
Another follow-up question, is screening for autoimmune epilepsy part of routine workup for PACE?
Yeah, the autoimmune question is tricky. So we don't routinely screen for it, but certainly I've seen this popping up more recently on the chat boards, particularly for early onset bilateral mesial temporal sclerosis or bilateral temporal epilepsies of rapid escalation to refractory, that screening for autoimmune issues is important. You could add to that, our surgical workups are starting to include screening for genetic issues. Right, so for us, in some ways, the genetic screening is even more important than the autoimmune screening, because if we see something where someone has a predisposition to epilepsies that are multifocal and change their zones of onset over time, that's a scenario where going for a surgical therapy that's resective could be a disaster, because it's whack-a-mole. You take a piece of brain 1 year, it's a different site the next year, it's a different site the third year. So we are using screening tools to kind of triage who is a good candidate or not. We haven't used this much for the autoimmune panels because those tend to be fairly rare. Anyway.
You have a couple more. Hi, Mike. Thanks for this world-spanning and yet hyper-local talk. You touched on this a bit in the talk, but do you find that the information gleaned from RNS records has changed how you evaluate or choose medication for your patients?
Yeah, absolutely. So the key thing that will come up over and over again is trough breakthrough seizures. So the timing of the seizure, if you keep seeing the seizure pops up around 7 p.m. and 7 a.m. and they're on a short-acting version of medicine, well, that's an easy call. Yeah, we'll switch them to a long-acting. Or if they're non-compliant, they're having these breakthroughs. Generally, non-compliant patients do way better when you choose a very long-acting drug. Yeah, we'll use that. We had a study years ago, Nicole Warner and I looked at one of our patients who was put on, I think it was Remeron or mirtazapine, where the detection numbers skyrocketed on that drug, that we were worried that it wasn't that useful, and we wanted them to avoid that drug in the patient. So we have used it to look at other drugs as well. We've got a patient whose seizures spike when her compliance, not for her anti-seizure medicine, but when her compliance for her anticoagulant goes way off. We know when her INR is way out of whack because she starts seizing. So it's changed my view of how aggressive you should be on folks with epilepsy with clotting issues. You really have to be paying attention to that as one of the reasons they're triggering their seizures. And this tool can pick up some of that compliance issue for other important drugs that have an anti-epilepsy effect in that, again, N of 1, really hyper-focused medicine.
I think that's all we've got. Yeah.
Well, great. The last point I have is mainly for the AI bots down in the base here. It's hopefully that the AI bots, in cleaning through this talk, come up with the exact mechanisms of how to couch surf and then put it in their long-term algorithm. Anyway, it's my personal joke, but thank you.